Dear colleagues, guests, and friends, I am Budi Iman Santoso from Indonesia, and I am going to present about the importance of the pelvic floor dysfunctions, particularly for women in Southeastern Asian region. There are 6 main topics for this session, which are women and the silent epidemic. Second, a pelvic floor dysfunction at glance, and pelvic floor dysfunction in Southeast Asian women. Management strategies, early detection, and strategies for Southeast Asian countries. Due to very limited time, it is not possible to provide detailed information. However, I would like to offer the overall perspective about those issues. One is women and the silence epidemic. Dear colleagues and friends, first of all, let's talk about women. This topic is very important as it is the central subject of our expertise, isn't it? Well, we can all agree that women in general, they need to be respected and loved, as none of us would come to this world without being carried in woman womb, wouldn't be. And also, we all know that the greatest love of all is a mother's love, and it is our duty to take care of them, providing a better quality of life. But sadly, women's health is often being disregarded and abandoned. In our field of urogynecology, one of the main problems in women's health is pelvic floor injury. Many women who become mother and have given birth naturally get affected by pelvic floor injury, which cause pelvic floor dysfunction. This condition has been ignored and pelvic floor injury becomes a silent epidemic. And second, we talk about pelvic floor dysfunction at glance. Let's take a look on pelvic floor dysfunction. Pelvic floor prevalence is quite high as it affects every 1 in 4 women. Pelvic floor affects every 1 in 4 women with prevalence of 24% in US women. It is observed in 41% of women in age range of 50 to 79 years. Pelvic floor dysfunction, which is prevalent in developing countries, as a urinary incontinence is about 29%, and fecal incontinence is about 7%, and pelvic organ prolapse is about near 20%. Vaginal birth is the strongest risk factor, and other factors may also play a role, such as obstetric and maternal factor. Risk factors is a vaginal birth is the strongest factor of pelvic floor dysfunction. Obstetric factors like multiparity, vaginal birth, high-grade perineal laceration, fetal position, height and weight, instrumental delivery. And maternal factor is age, height, BMI, family history of pelvic floor dysfunction, and ethnicity. The role of cesarean section on pelvic floor dysfunction has been debated for years, but recent evidence show its protective effect. However, it is still controversial, and high-risk women needs to be evaluated carefully through early detection measures. What about a cesarean section versus vaginal delivery? Cesarean section may have protective effect for pelvic floor dysfunction in vaginal delivery. A systematic review of 56 articles found that prevalence of urinary incontinence is lower in women with cesarean delivery, but the protective effect decreased after the woman reached 50 years old. There were no difference of fecal incontinence incident in both groups. The risk is increased with operative vaginal delivery or anal injury. Cesarean delivery protects against pelvic organ prolapse. Role of elective cesarean section. Elective cesarean section in general have limited benefits and still controversial. In high-risk women of pelvic floor dysfunction, offering the choice of elective cesarean delivery is appropriate to prevent pelvic floor dysfunction. How high the risk threshold? Now we talk about pelvic floor in South Asian women. Asian women, especially in Southeast Asian region, they are wonderfully strong with rich culture. In particularly area of my country, they are often the breadwinner, and we often see them carrying heavy load on their head, either for the sake of daily living or cultural duty. South Asian woman is unique, wonderfully strong with rich culture, often the breadwinner, often see them carrying heavy load on their head, either for the sake of daily living or cultural duty. Now, let's see the pelvic floor issue in East Asian region. Most women in Southeast Asia country have little knowledge about pelvic floor disorder. And there is a difference in management of pelvic floor dysfunction among Southeast Asia country. And guidelines of Western country are difficult to be applied due to different conditions and situation require specific modified strategies. We need solid collaborative commitment in the Southeast Asian region. While in the Western country, this problem has been priority and managed quite well. But in Asia, particularly in our Southeast Asian region, the problems remain hidden, if not abandoned. Asian women tend to be shy and have to act strong solving their own problem. So when they have pelvic floor injury, they tend to be silent and bear it by themselves until it is all too late. The defect might be too severe to be repaired even by reconstructive surgical treatment. Hence, we are doomed to face the problem at this most severe state, and nothing can be done about that. Therefore, it is important to raise the awareness of this silent epidemic. It should be a wake-up call for all of us to develop early detection strategy before it is too late and we can do nothing to help the patient. And now we talk about the management strategy. So what are the management strategy for the issue? Treatment of pelvic floor dysfunction is challenging in terms of high recurrence rate, significant effect on quality of life, high cost, and long term of treatment. Therefore, prevention and early detection is the key. When we detect early, we treat better. Prevention is the best treatment. And we talk about the how to early detection. There are two important aspects in early detection, which are methods for predicting the risk to develop pelvic floor dysfunction and the tools for predicting the risk to develop pelvic floor dysfunction. Yellowsack, Soligo, and Ayuga, with its brilliant acronym, we call it Your Choice, regarding the tool for predicting the risk. There are MRI. We can use MRI, ultrasound, with smart pelvic, of course. Predicting the risk of develop pelvic floor dysfunction from Yellowsack et al. Found that in their longitudinal study, family history, route of delivery, urinary incontinence before and during pregnancy are strong predictors of pelvic floor disorder. And Soligo et al. Made a multivariable analysis and found that symptoms of incontinence before and during pregnancy with odd ratio is 1.7 and 2.1. Vacuum extractor with odd ratio 1.6. Severe perineal tears with odd ratio is 19.4 are associated with pelvic floor dysfunction. Ayuga in Dublin made a predictive scoring of future pelvic floor dysfunction following childbirth based on two large longitudinal study we call it Your Choice. It's mean you can rate in that. U is mean urinary incontinence before pregnancy. R is race or ethnicity. C is childbearing age. And H is height, is mother height. And O is overweight. We call it BMI. I is inheritance, is family history. C is children, number of children desired. and A is estimated fetal weight. Tools for early detection, there was some sign to detect injury to perineal muscle. The factor age. Avulsion is significantly etiology of in broad organ pelvic development in the future. Physical examination using finger, you can see it in the slide, can be used to detect this abnormality. The best modality to detect prefrontal injury is using MRI. However, there were obstacles in using MRI for early detection, of course. You can see here, this is the left side, there is before delivery, and the right side is after delivery. You can hiatus is more wide. You compare, and perineal measurement is, is height before and after delivery. And we know it's the problem of MRI is, I think, is we need the patient to be complete. It's still expensive fee, and the problem is patient with the metallic implant are not suitable, and display anatomy not in a dynamic state. The ultrasound allows real-time, dynamic, non-invasive, and cheap, and quickly to assess pelvic floor, and we can call it smart pelvic. Is in ultrasound program, is designed for clinical utility in assessing pelvic floor. So with the smart pelvic, you give many advantages with its big data algorithm. It is auto measurement of anterior pelvic floor compartment, elevator hiatus evaluation, indicator measurement, annotation reference, and efficient and easy to learn. And 5 times faster than ordinary ultrasound. Yeah, you can see here, I think it's this by for MRI. And but not every hospital or not patient suitable for this technique. So we have the problem with that. And also, of course, we can use the method of smart pelvic with ultrasound. We have 5 times faster if you compare with the ordinary ultrasound. And about the strategies for Southeast Asian country. Specific strategy need to be developed for Southeast Asian region. In this region, of course, it has different and unique situation than other countries, considering the culture, geographical, and socio-economic challenge. So the strategy may include modified guideline, focusing on early detection and prevention. We use the predicting risk factor. We call it BISA score. Or, of course, you use the ultrasound. And we need the multi-center studies, building regional data, and international support continues with, of course, the IUGA members. Let's talk a little bit about BISA score, as it is a practical method used in Indonesia to determine women who are at risk having a pelvic floor dysfunction due to vaginal. So BISA score is come from, I'm sorry, it's come from my name. We call it Budi Iman Santoso assessment score. we have the research for this for 2 years, and the result is we call is BISA score. And this scoring has been developed to represent a role of demographic risk factor, BMI, and obstetric risk factor. And a woman at high risk should be suggested to have the ultrasound, 3D or 4D, or pelvic floor examination for levator injury in 3 months after delivery, if you want to make sure that is the what happened with the levator eye. Here are BISA scorecard can be used in daily practice. For example, we have 2 kind of BISA score. This is the model 1. This have the 4 variable here. We can use the episiotomy and stage of the second labor and fetal birth weight. Sorry, we use the 3 variable. If the episiotomy you done, you just tick yes, and the second stage of labor, if the more than 65 minutes, you can take the score 2, and fetal birth weight more than 3,325 grams, you take that is score 1. And totally there is positive, it be score totally is 4, and predictive value is about near of 90%. This is the high risk, is total score is 3 and 4. And low risk is 0 to 1, and moderate risk is score is 2. If you use the model 2, there is 2 variable. It's mean a perineum rupture. It mean is the totally sphincter. We call is grade 3 or more of the grade 3. We call is oasis of obstetric sphincter and injury. If you find it, you can tick yes. If the score is 2, its second stage of the labor is more than 65 minutes, you can tick this variable in score 1. And totally, the score is 3, is all of 2 variable is positive. The prediction value is about 88%. So this is a high risk. Yeah, the high risk is 2 and 3. So we can explain give the education for the patient what to choose, the best choose that they must be happen to the patient. Yeah, they can try with the delivery normally, or he want to go to the C-section. If she become delivery and success of delivery, and you can ask her to come to the clinic, on your clinic, to examine the pelvic floor with smart pelvic 3 months after that. So for the conclusion from our presentation today, now we have come to the end of the presentation. In brief, I can say that early detection is a real important action that we can do to prevent further complication of pelvic floor dysfunction. Specific modified guideline for Southeast Asian region need to be developed. I believe that this issue should be concerned by all of us. We can manage the problem together as a solid team worldwide, as the problem is indeed a global issue. Southeastern Asian countries need to develop their own modified guideline to address this problem, and we should give our full commitment to solve the problem for our women who have been suffering so much. They need what they deserve. Let's get work together and provide better quality of life for our women in the Southeast Asian region. Thank you for your attention.
Xin cảm ơn phần trình bày của thầy Budi Iman Santoso về tầm quan trọng của việc phát hiện sớm tình trạng suy yếu cơ sàn chậu và để ngăn ngừa rối loạn chức năng sàn chậu trong tương lai. Tiếp tục chương trình sẽ là bài giảng của thầy Fernandi Moni về phát hiện Dạ, em xin phép share bài.
Here I would like to share our experience in using ultrasound, especially in pelvic floor, to detect the pelvic floor muscle weakness. Since pregnancy, before and also after childbirth. So this is my CV, and the outline of this presentation is I would like to share and to explain about what is it called, the levator ballooning, avulsion, and also the urethral hypermobility. How those can be detected in late pregnancy and after childbirth, and after that we could have the take-home messages. So the objective, to know how to detect risk factors. What are those? About levator hyperballooning, avulsion, and urethral hypermobility. This is very important for pelvic organ prolapse and stress urinary incontinence incidents. And we could detect those by ultrasound since late pregnancy until after childbirth. So this is the problems. What is it called? The pelvic organ prolapse. It's very, I think it's a very disaster. And also the other one is, what is it called? This is stress urinary incontinence. When a lady could not hold urine during the when she cough, sneeze, or doing exercise. Those what we call the pelvic floor dysfunction. And of course, those could happen because of this. This is our pelvic floor, and it could be what is called weakened or damaged during the childbirth. And actually, it's starting since pregnancy. I will show you that during the pregnancy, all of those pelvic floor muscles already been weakened. And the worst case is if those weakened pelvic floor cannot go back to normal after a childbirth. So this is the imaging from ultrasound. This is the pelvic floor, and this is the levator hiatal. And this is a normal one, and you can see which is very different if this during the falsafah, of course. The patient, we asked to do a maximal Valsalva, and then we could see, yeah, how big or how large is the levator hiatus muscle, yeah, because of the Valsalva. And if the muscle is still good, yeah, then it's still normal, yeah, less than 25 centimeters square. But if it is already weakened, then when doing maximal Valsalva, then we could see that could be this is a very severe ballooning, yeah, 52 centimeters square. And this overdistended levator hiatal ballooning is a microtrauma. The worst case, worse than this, is what we call the macro trauma or avulsion. Yeah, avulsion means it detached. Yeah, you can see that if the defect is so severe that it not only overdistended, but it detached also. Yeah, from the insertion or the origin. Yeah, at the symphysis pubis. Yeah, like this. So, according to Professor Deed's study, those two, which is called avulsion, the detach of the levator muscle, and also the ballooning, those two are two independent risk factors for prolapse. Yeah, it already been determined, yeah, since 2011. And also, yeah, I would like to share the incidents around the world and in my country, yeah. How is the avulsion injury? Yeah, according to the study from Clara Scheck, this is also from Professor Deed's group in 2010. The incidence is around 13, but it can be nearly 50%. Yeah, in the latest study in 2021. Also, this is a study from Professor Deed's group. Yeah, yeah. So the avulsion incident is in I think in Caucasian is quite high, but in Indonesia, yeah, in Malay race, yeah, those avulsions incidents it's quite low, yeah, because we can see several studies from our country in 2016. Among Paris women is only 2%. Among prolapse case is less than 10%, then among symptomatic or severe prolapse cases, most only 10%. But how about ballooning? Yeah, those overdistended. Yeah, according to study around the world, yeah, you can see it's not many. Yeah, mostly around 20%. But in my country, I think it's very high. There is a study from 2014. Among prolapse cases, the rate is around 60%, but actually, if we divide it and differentiate between prolapse asymptomatic, stage 1 is only 30%. But in symptomatic stage or severe prolapse, we can see it's very, very high. And these are numbers among prolapse cases, but how about cases during pregnancy and after childbirth? So this is my latest study, which is going to be published. Yeah, during 30 weeks of brevi gravida, yeah, it's nearly 20% already. I found ballooning already happened, and after childbirth, it's getting twice. Yeah, it's nearly 40%. So there is also a good study here, a quite late study from China, I think. Yeah. So this study going to have association between the hiatal dimension and what is it called, urethral hypermobility. Yeah. So the conclusion about the larger the hiatal area was, then the bladder neck mobility will be much more. Yeah, you can see later. Yeah, so it is have a good correlation or association. Yeah, another study from 2014 from group from Netherlands. Yeah, they also have a result that during pregnancy, women with stress urinary incontinence already had a significantly larger hiatal area compared without. Yeah, and also after childbirth, more caudal and dorsal position of the bladder neck means that more hypermobility of the bladder neck and urethra. So those makes the stress urinary incontinence, of course. So yeah, so this is what we do to have a imaging or do scan of pelvic floor muscle, and then so we placing the probe like this. Yeah, of course, we cover it with the plastic or gloves. Yeah, and then so this is the picture. Yeah, this is the picture we could have. Yeah, this is the symphysis. This is the urethra, bladder, and this is the anorectum, and the vagina is in between, which is quite difficult to see actually, because vagina, there's nothing inside there. What is the vagina, and this is the uterus actually. Yeah. So okay, if we have a 3D facility, then we can have a render volume, yeah, of this levator ani muscle, yeah, like a V shape or U shape. Yeah, so this is the urethra and this vagina, and this is the anal. Yeah. Yes. Yeah. This is the picture. We could compare it with the picture. Yeah. This is what is our pelvic floor muscle. Yeah. This is a very good imaging we could have if we have a 3D, 4D ultrasound facility. Yeah. Okay, so what we have for over the standard ballooning microtrauma. Yeah. See, yeah, if the patient has to do a maximal falsava, and then we have the imaging, and then we could measure. Yeah, so the cutoff point is 25 centimeters square. Yeah, if it is less, then there is no ballooning. If it is larger, then this is of course the ballooning. Yeah, like this patient after the childbirth. Yeah, this is the study from Professor Dietz as well in 2008. And yeah, I could show you. This is what the patient in rest, and then asked to be falsava, and then this hiatal area will be getting bigger and bigger, or larger and larger. Yeah, when after the maximum, and then we could freeze, and then we could measure it, whether it is less or more than 25 centimeters square. Yeah. Another way, if we don't have the 3D, and then we could also diagnose the ballooning with 2D. Actually, yeah, this is the way we have already the 2D. Yeah, symphysis, urethra and bladder, and this is anorectum, and so this is the posterior of the levator anal muscle. So during the maximal falsava, yeah, we also can measure how large or how is the distance between symphysis and the levator anal muscle. The cutoff point is around 6 cm. Yeah, so like this, if the maximal falsava it's less than 6 cm, then still normal. But if like this, it's getting longer, more than 6, then it could be determined as a ballooning. Yeah, this is also a study from group of Peter Dietz. Also, another group from China have a same study, and they also have this all exactly the same. The cutoff point is around 6 cm. Yeah, to determine between non-ballooning and ballooning. Yeah. So I would like to share what we what we measure from symphysis until here. Yeah, I would like to share. This is in rest and then doing for sulfur. See, this is getting larger and larger. And then when the maximum, and then we could measure it. Yeah, how many centimeter? Actually, this we measure the anterior to the posterior of the hiatal. Yeah. Okay, we move to the next one, which is called the avulsion of macrotrauma. Yeah, this is like previously I've already mentioned that this is actually detached. Yeah, so basically the levator anal muscle should be have an insertion or origin in the symphysis pubis. Now, when there is some detach, yeah, this is unilateral detach in right side, and we can see difference between the left side. Yeah, this is from ultrasound imaging, and this is from MRI. It's the same. Yeah, and clinically it's quite difficult actually to see. Usually this detachment, this avulsion happen after a very difficult childbirth, maybe using like forceps or some, and then we have a very deep very deep wound, yeah, here in vagina, lateral of vagina. Then there there might be some avulsion. Yeah, so with ultrasound it's very easy. This is normal. This is unilateral right avulsion, and this is a bilateral, yeah, left and right avulsion, yeah, with 3D ultrasound. Yeah, this is one of my patients. Yeah, I have a right side of avulsion. And also Professor Deeds already have a study with a cutoff point of 2.5 centimeters. Yeah, if we have this is what is it called, multi-slice ultrasound. Yeah, so we could see that we could measure it from urethral until this is the most lateral side of the levator anal muscle. Yeah, if it is more than 25 millimeters, this could be diagnosed as an avulsion. If less, then it is normal, still intact. Yeah, like this. So this is the example. Yeah, this is a normal one. If we measure from urethra until the levator anal, then this is less than 25 millimeters, or this is a bilateral avulsion. Yeah, so right and left avulsion more than 25 millimeters. Yeah. Okay. Again, if we don't have a 3D 4D, we could also still diagnose with 2D. Yeah, like this. Yeah, after we placing the probe midline, and then we could tilt it. Yeah, to the right or to the left. Yeah, around 20 degrees. Yeah, so we could have imaging like this. Yeah, this is the muscle. Yeah, this is the puborectalis muscle, and this is the place where it is have a insertion or origin in DF symphysis pubis. Yeah, this is a normal. Yeah, it is stick to the bone, right? Yeah, but yeah, this is a normal one. Yeah, this is the muscle, left and right. Yeah, this is example from my patient. Yeah, and the difference, if yes, this one is a difference. Yeah, we could see there is a black area. Yeah, so this is a detachment. Yeah, or avulsion. Yeah, of the levator anal muscle. Yeah, it's very easy to be determined or to be distinguished. Yeah, this is also example from my patient. Yeah. This is a detachment. Yeah, avulsion right and left. Yeah. Okay, so yeah, this is I would like to to show, yeah, how we could have that kind of imaging. This is from midline. Then when we tilt to the right, yes, this is the muscle, and then we could ask the patient to contract, yeah, so we could see the muscle very good, yeah. This is in the right side, and if we go to the other side, this is the left side. Yes, this is the muscle and having a better one when doing contraction. Okay, so the third one is about urethral hypermobility. Yeah, already been discussed. This is the urethra when doing Valsalva. If the urethra and bladder is, yes, is moving, yeah, it is moving much more, so that would be a stress incontinence then, yeah. So the parameters we could have, there are some several parameters, yeah. You can see here there is what we call, this is a retrophysical angle here, and then if since before Valsalva and after Valsalva, we see there is a changing of the urethra, and then there is an angle like this, which is a urethral rotation angle. Yeah, so we could also measuring this angle. So basically we usually measuring the retrophysical angle, urethral rotation angle, and also the bladder neck descent. Yeah, so the moving of the bladder neck here. Yeah, since before the distance here and after the maximum Valsalva, then the bladder neck is moving higher than the same which is here. So here plus here is the distance, what is called the BND, bladder neck descent. Yeah. Yes, and also there is a funneling. Yeah, when doing maximum Valsalva, if there is a funneling like this, so this is also a typical of stress urinary incontinence. Yeah. So there are several studies from around the world. Yeah, this is from Arab Journal. Yeah, they measuring the retrophysical angle and cutoff points around 141 degree. Yeah, for retrophysical angle. And there's another study from China, and they have a cutoff point of around 2.5 centimeters for bladder neck descent, and for urethral rotation angle around 45 degrees. And my study with my resident, yeah, this has already been presented in last December, yeah. So this is our measuring in late third pregnancy, yeah. So there are nearly 30% of women in late pregnancy already have stress urinary incontinence, and our cutoff point, yeah, the bladder neck descent is around 1.7 centimeters or 1.8, and the retrophysical angle around 155 degrees, and the urethral rotation angles around 30 degrees. Yeah. Okay, so this is the reference. Yeah, we have the BND. Yeah, if it is like more than 2.5 or 3 cm, retrophysical angle, if it is more than this, yeah, and then the urethral rotation angle more than like 30 degrees. Yeah. So yeah, with imaging, yeah, of course, those are the parameters. Yeah, this is what is the distance between bladder and symphysis or BSD, and then bladder neck descent will be calculated after the maximum Valsalva, and then this is retrophysical angle, yeah, and also the urethral rotation angle later, yeah. So I would like to share, this is one of measuring by the smart pelvic. Yeah, we have a very good application. Yeah, this is very easy, we do. Yeah, so like this. Yeah, this is the indicator. Yeah, So it's very easy, yeah, to measure with smart pelvic, yeah, smart pelvic application. Yeah, we only have to yeah, to point out all of these several points here. This is S for synthesis. You place it here, and then after that, continue replacing the bladder neck, yeah, the urethral, and then this is the urethral proximal. This is retrovesical wall, yeah, and then after that, okay, we already have the, sorry, yeah, here, and then automatically after we just put all of these points, then the computer or the smart pelvic will count for us, yeah, those parameters, yeah, and then we continue it. This patient has to be maximal for salva, and then we can see the moving, yeah, of the bladder again. Point the symphysis, and then the this is the bladder neck, urethral, retrovesical wall, and then the computer will automatically counting for us. Yeah, yeah, we can see here, yeah, that the bladder neck descent 2.5 cm, the retrovesical angle 166 degree, and so on, and the others. Yeah, it's very simple. Yeah. Another one I would like to share. This is much easier. Yeah, if you would like to measure the hiatal area, yeah, with this smart pelvic, we only have to point this only two. Yeah, this is the center of the urethra, and then this is the anterior border of the posterior of the levator ani muscle. Yeah, like this. Yeah, first point. This is the center of urethra, and then the next one is this, and then the computer will calculate automatically for us. Yeah, we already have lots of measurement like the area. Yeah, like 20 cm square. Yeah, and then we also have this. If the patient we ask to do contraction, when we also can have the measurement of the levator ureter gap. Yeah, the 2.5 cm I already mentioned before. Yeah, so it's very easy. Yeah. Okay. So, and there are also some another multi-slice. Yeah, if we have a full multi-slice facility, then we could have a more detail in measuring those. Yeah, this is another sample. Yeah, for yes, symphysis, bladder neck, proximal urethra, and then retrovesical wall, and then yeah, the most distal, and then save all those measurements, and then ask the patient to do maximal Valsalva, and then you can see the movement of the bladder and the urethral. Yeah, it's moving up, but actually it's coming down because it's upside down. Yeah, actually this is going down. Yeah, measure again, symphysis, and bladder neck. You can see there's a funneling here. Yeah, and this is the proximal urethra, retrovesical wall here, and then the computer automatically counting for us. Yeah, retrovesical angle, the neck descent, and so on. Yeah, it's very easy. Okay, so my take-home message is so we from ultrasound, yeah, we could have imaging for risk factors for POP and stress urine incontinence, especially with ballooning, avulsion, and urethral hypermobility. Yeah, so with this ultrasound, we could have all of this cutoff point. Yeah, so those cutoff point or those measurement would much help us. Yeah, in determine which patient, yeah, which patient of us that would have a risk factor to have a prolapse and stress incontinence in the future. Yeah, we can measure this ultrasound examination during late pregnancy. and then after childbirth. Yeah, so if the patient, yeah, after childbirth, she doesn't have any complaint, yeah, or any problems right now. But if we already have this kind of examination, so this can be prevented. Yeah, we could starting our therapy, yeah, like Kegel exercise, yeah, or we could have several modalities like laser treatment, like magnetic chair or anything. Yeah, so we could prevent the patient to have a severe condition that only can be treated only by surgery. Yeah, that's the goal of us. Yeah, so we could have a good screening for our patient, and then we could ask the patient to do some conservative treatment, something like that. Yeah. All right. So yeah, this is my reference, and after this, I would like to share a video, yeah, to show you how we measure the patient with smart pelvic application. Thank you very much. I'm Dr. Fernandi Mugni. I am an obstetrics and gynecologist, subspecialist in urogynecology, reconstruction, and aesthetic. In this video, I will introduce how to use Smart Pelvic feature from Mindray. For women who have a normal delivery, history of uterine surgery, obesity, old age, they have risk factors of having disease called pelvic organ prolapse or POP and stress urinary incontinence or SUI. A condition in which women having descent of her pelvic organs and also unable to hold urine. Pelvic floor ultrasound can be used to evaluate and diagnose this problem. During the evaluation of POP and SUI, when doing measurements usually is time consuming. Mindray created a unique smart feature named Smart Pelvic, which can evaluate the anterior compartment and levator hiatus automatically. The following is the preparation before the examination. After filled in patient data, press the probe button and select Probe Volume Convex and the pelvic floor application on the touchscreen. Patient preparation. The patient must emptying her bladder before undergoing the pelvic floor ultrasound examination. Patient remove the lower underwear, positioning in lithotomy position, heel close to the buttocks. Now we will start examine the anterior compartment of pelvic floor with Smart Pelvic. Apply the gel until it covers the surface of the probe like this. It is important for us to check the condition of the probe first. Then we apply gel to the top surface of the probe. Attach the transducer to the perineum. The transducer position should be longitudinal, with the directional probe marker at the 12 o'clock position. Now we will get the standard sagittal cut for the pelvic floor. In this piece, we can see the symphysis, urethra, and the bladder. There are 3 organs that can be used as markers for standard sagittal sections. Pay attention that the distance between the surface of the probe and the symphysis is not more than 1 centimeter. This will make sure the image will be good. Okay, we'll save this image at rest condition first. Press the save button. Currently, we will do measurements of the organ in rest condition. Press Smart Pelvic on touchscreen. Press rest. If you need more measurement parameters, select Measurement Parameter on touchscreen. Then press Measure, then take measurements based on the indicators on the screen on the left. The following are the measurement points that will be pointed. S for the lower limit of the symphysis, U, urethrovesical junction, E, the proximal end of the urethra, R, retrovesical wall, V, lowest point of the retrovesical wall. Then all the following measurement results will be obtained. Press the Save button to save the image with measurements in rest condition. Next, we will ask the patient to do Valsalva maneuver. Instruct the patient to perform maximal Valsalva until the urethra and bladder position moves from the symphysis maximally. Push, push, push. Good. Then freeze. Take measurements by pressing Valsalva on the touch panel. Then press Measure and follow the measurement steps according to the indicators on the monitor screen. Next, we will measure the levator hiatus using 4D function. First, take an image in rest condition. After seeing images of symphysis, urethra, bladder, vagina, anorectal and levator anal, then slide the 4D button to the right side. Press Set to enlarge the region of interest by sliding the trackball, then press Set again. After that, then press Update. Press Dual to display the image into two left and right windows. In the left image, slide the trackball to get an image of the symphysis and the levator anal muscle in the region of interest box. When sliding the trackball, look at the volume rendering image on the right. The benchmark is to the position where the image of the symphysis begins to split in two. Make sure that the levator anal muscle is clearly visible inside the area. Instruct the patient to do Valsalva maneuver maximally until the levator anal muscle is maximally open. Push, push, push. Yes, good. Then press Freeze. Press Smart Pelvic VR on the touchscreen. Then click Valsalva. Put the first cursor at the center of the urethra and the second cursor at upper edge of the lowest levator anal muscle. Then press Set. The tool will trace automatically. If the genital hiatus measurement is not matched, it can be edited. Press Edit on the touch panel and several points will appear in the measurement area that can be used to edit measurements. Slide the rectangular cursor through the trackball to a point, then press Set button so you can change the measurement by dragging the point to the appropriate measurement location. Editing can be done at any point. The following measurement results will be obtained. Then save the image by pressing Save. Note, then repeat the procedure as before. Take picture in the patient's condition of maximal contraction of levator anal. muscle. After seeing images of symphysis, urethra, bladder, vagina, anorectal, and levator-anal muscle, then slide the 4D button to the right. Press Set to increase region of interest. Slide the trackball and press Set again twice. After that, press Update. Press Dual to make the image into two windows, left and right. Then instruct the patient to perform maximal pelvic floor contraction. Squeeze, squeeze, squeeze. Yes, good. Then freeze the image. After the image of levator anal in maximum contraction has been taken, press Smart Pelvic VR. Put the first cursor at the center of the urethra and the second cursor at upper edge of the lowest levator anal muscle. Then press Set. The tool will trace automatically. Then save the image by pressing Save. Smart Pelvic from Mindray Ultrasound can assist doctors in conducting pelvic floor examinations more easily and quickly, so that the patient feels comfortable and the doctor can shorten the time of examination. Thank you.
Xin cảm ơn phần trình bày của thầy Fernandi. Và để không làm mất thời gian thêm của quý bác sĩ, em xin đi đến phiên thảo luận Q&A của hội thảo. Em xin phép được giới thiệu thành phần tham dự của phiên này bao gồm Phó giáo sư thầy Nguyễn Phước Bảo Quân, Chủ tịch Chi hội Siêu Việt Nam, bác sĩ Lê Thị Thanh Thảo đến từ Trung tâm Y khoa Medic, và giáo sư bác sĩ Budi Iman Santoso, Chủ tịch Hội tạo hình phụ khoa tiết niệu Indonesia, và thầy Konani Moni, trưởng bộ môn siêu âm sản phụ khoa Y Đại học Indonesia. Trước khi share Q&A giùm em. Hello everyone, now we go into the Q&A session. So on the panelists, please open your camera. Thank you. Okay, now I will open the Q&A for this session. Dr. Thảo will be our interpreter for this session. Okay. We have 4 sessions for today webinar. Em mời bác Thảo ạ. Có 4 câu á chị.
First one's participant ask a question for Professor Budi. Okay.
Yes.
How frequently we can perform the pelvic floor ultrasound for early detection for pelvic floor dysfunction? Thank you.
Thank you. I'm sorry I cannot open the video, but I want to ask. Maybe
Sorry.
after that, maybe Dr. Fernandi will add my my answer. How frequent? We usually in pregnant woman, we start with 36 weeks of gestation. Yeah, you can find about 2.5% will be the injury of the pelvic, because the pregnancy is the ones of the risk factor of has become the levator-anal avulsion. So after that, maybe after 3 months, 6 weeks or 3 months, you can continue with the use the smart pelvic. Of course, if you want to know about the levator-anal avulsion. Yeah, but I think maybe Dr. Fernandi would ask, you can measure it about the mobility of the urethra. Of course, when the from the pregnancy and after the postpartum period. So I think this depend to the what you want to see about the injury. But for the screening, it's better start with pregnancy, or maybe you can use the PISA score. If the high score, maybe you can ask the patient to come to measure about the pelvic floor. Yeah, of course, be smart pelvic. Maybe Dr. Fernandi will add the answer. Yeah, please, Dr. Fernandi.
Yeah, thank you very much, Dr. Prabudi. So yeah, that's a good question. So yeah, like Dr. Budi's already mentioned that, yeah, of course, when is the best time during pregnancy we can do screening, of course, the latest. So it around 36 and more, yeah. So 36 until like 40 weeks, yeah. So we hope that at that weeks of pregnancy, they're already been changing, yeah, in the pelvic floor muscle, yeah, some weaken or some elastic, something like that, yeah. So we can see the ballooning or and hypermobility and something like that. And after childbirth, yeah, we can do like at the after puerperium, like 6 weeks or 40 days, and also 3 months after, yeah. So I think those time is also the time then we ask the patient to come for us to do the visit, yeah, like after puerperium, 6 weeks or 40 days, and also 3 months after the labor. I think that's the question, the answer. Thank you.
Okay, thank you, Professor Pratik and Dr. Fernandi. Cái câu hỏi là mình sẽ hỏi là việc cái theo dõi phát hiện sớm các rối loạn sàn chậu sau sinh thì nên thực hiện siêu âm bao lâu một lần? Thì theo ông Budi thì ông cho rằng là trên 50% phụ nữ sau sinh sẽ có những cái triệu chứng ví dụ như đi tiểu không kiểm soát khi mà gắng sức. Chính vì vậy thì theo ông thì cái việc theo dõi siêu âm sau sinh thì có thể chúng ta sẽ thực hiện 3 tháng hoặc là 6 tháng sau khi sinh. Và trên siêu âm thì chúng ta sẽ tìm những cái dấu hiệu như nãy giờ chúng ta đã nghe. Ví dụ như ông Fernandi thì ông nói là mình sẽ tìm những cái dấu hiệu ví dụ có cái giãn hoặc là cái rộng cái khe cơ nâng sau sinh hay không. Thì ông Fernandi thì ông cho rằng là mình có thể theo dõi 6 tuần, tức là khoảng 40 ngày á, hoặc là 3 tháng sau khi sinh. Và ông Budi thì còn cho rằng chúng ta sẽ trên lâm sàng thì chúng ta sẽ dùng thêm cái chỉ số PISA score, đó là cái chỉ số mà theo cái nghiên cứu của ông và các cộng sự trong vòng 2 năm. Thì nếu như mà cái chỉ số này nó có cái yếu tố tiên đoán cao, nó nằm trong high risk đó, thì mình sẽ nghi ngờ bệnh nhân nó có cái rối loạn chức năng vùng sàn chậu và mình nên cho thực hiện siêu âm kiểm tra. Rồi bây giờ mình sẽ qua tới câu hỏi thứ hai ha.
Câu hỏi số 2.
The second question from Dr. Fernandi. Yes. Whether the pelvic floor ultrasound already had the standard protocol or we just evaluate it depends on clinical requirement only.
Okay. Okay, thank you very much. Good question also. Yeah. So in our unit, yeah, we are starting, yeah, to have this kind of protocol as a standard. Yeah, not yet actually, but as we already know that Prof. Budi already mentioned about ladies with risk factors, yeah, of course they should have this kind of screening, yeah, since late pregnancy, yeah. But yeah, if later we have data from lots of countries, yeah, like our Southeast region, and if we have like in my country, in Indonesia, ballooning since pregnancy itself already been happened like nearly 20%, something like that. If it is yeah, it's quite important that maybe we can build this kind of ultrasound screening as a protocol. Yeah, and of course after childbirth, yeah, it can be twice. I mean the number of ballooning, yeah, like nearly 40%. Okay, that's my yeah, and also the hypermobility and stress urine incontinence is around 30% already been happen during pregnancy. Yeah, so I think those numbers would be make us to make this as a standard protocol in the future. Thank you.
Thank you, Dr. Kennedy. Câu hỏi ra là mình trong cái siêu âm sàn chậu á, mình có một cái trình tự hay một cái protocol tiêu chuẩn nào không, hay là mình chỉ khảo sát theo yêu cầu của lâm sàng? Thì ông Kennedy ông cho rằng thì ở trên đất nước của ổng thì cái siêu âm sàn chậu nó không có một protocol tiêu chuẩn nào hết, mà ví dụ như khi mà phụ nữ sau sinh á thì vô siêu âm sàn chậu thì ổng sẽ kiểm tra coi thử là bệnh nhân có giãn khe cơ nâng hay không, hay là bệnh nhân có tăng tính di động của niệu đạo hay không. Đó là tùy theo cái bệnh cảnh lâm sàng của cái bệnh nhân. Rồi mình sẽ qua câu hỏi tiếp theo. The next question for Dr. Fernandes. Can you suggest what we should mention on the ultrasound examination report?
Okay, thank you very much. Yeah, this is a good question. So I think that three things that you should detect. Yeah, first is the levator height ballooning. Yeah, and the second one is if there is some avulsion, and the third one is there is some bladder neck or urethral hypermobility. So how to determine those three? Yeah, it's already been mentioned. Those parameters, yeah, we should examine, but with smart pelvic, those will be much easier to be examined. That's my question. Thank you.
Okay, thank you, Dr. Kennedy. Mình hỏi ông Kennedy là mình sẽ trả lời trong kết quả siêu âm như thế nào? Thì ông trả lời là đầu tiên là mình sẽ coi có giãn cái khe cơ nâng hay không. Cái thứ hai là mình sẽ trả lời đó là có rách cơ nâng hay không. Và cái thứ ba là mình sẽ trả lời bệnh nhân có cái tăng tính di động của niệu đạo hay không. Thì cái đó là ba cái phần chính mà mình sẽ trả lời trong kết quả. Thì ngoài ra mình sẽ còn thêm một số các yếu tố đánh giá, đó là những cái chỉ số mà mình đo lường trong cái kết quả khi mà mình thực hiện cái siêu âm sàn chậu. Rồi mình qua câu hỏi tiếp theo ha. Okay. The next question for Dr. Kennedy. Whether the final measurement result of every floor has different due to different times of measurement or different operators, and how can we for it in order to ensure high reportability of the measurement?
Yes, thank you very much for the question. So yeah, this is actually I'm not promoting this ultrasound actually, but I cannot say other than yeah, this is a very good application, yeah, this smart pelvic. Yeah, so if you raise an issue about this, about the different operators, different measurement, yeah, in my opinion, yeah, if we have this kind of application which is called smart pelvic, those different between operators maybe could be reduced, yeah, because it's making much more easy for us to examine both of those measurement, yeah, with only put those points, yeah, and then the computer will examine the result for us exactly. Thank you.
Thank you, Dr. Kennedy. Mình hỏi là liệu cách đo lường sàn chậu có sự khác biệt giữa các lần đo hay là giữa các người thực hiện khác nhau hay không, và làm thế nào để tránh cái vấn đề này để có thể có được một cái đo lường có độ lặp lại cao. Thì ông Kennedy ông cười và ông cho rằng cái vấn đề đo lường này thì nó tương đối đơn giản, chỉ khi làm mình sai số giữa các lần đo có thể là khi mà mình chọn những cái điểm, nếu mà mình dùng cái Smart Bandwidth của ManRay thì trong quá trình mình sử dụng những cái điểm mình đặt cái vị trí của các cái điểm để mà mình đo đó, thì mình lựa chọn những cái điểm đó nó không chính xác thôi, thì nó sẽ dẫn đến các kết quả đo nó sẽ không có chính xác và không có sự lặp lại. Rồi mình qua câu hỏi tiếp theo ha. Rồi, the next question for Professor Budi. Do we currently have any screen program for pelvic floor dysfunction? If yes, who should be screened?
Yes, thank you for our colleague question. I would like to answer this because, as you know, the best screening program is, you must be first the education for the midwife or for the GP. Maybe you can use the visa score. It's like that is more easy, but because it's especially for the primary parents. Yeah, this is my research that. So with the high risk, maybe you can you can screen. Yeah, you can know what is the high risk or not. Yeah, because it's no facility, because not every facility have the smart pelvic. So maybe for the next future, maybe maybe we can work together with choose what the standard equipment. So, but in our country we use the risk. You can use the risk. Whatever you want. So I asked. So I say already mentioned in my presentation. So for make the program or guideline here for our country is is rather different. If you use the result from the guideline from the Western country. So in this time maybe we can choose. You must be education for the midwife or the GP, especially in the high risk pregnancy. Yeah, for example, especially for the primary gravida. Yeah, you can measurement what is the model for this. You can measure about don't make the secondary phase is more than 60 minutes, and no the weight baby is more than 3,200 gram, and no episiotomy. Yeah, of course, episiotomy is done only by the indication. Yeah, or maybe if the GP or the midwife can make the diagnostic of the OASIS, obstetric anal injury, sphincter anal injury, maybe you can use the model 2. So it's very important. So the important thing is how to education about the midwife and GP, and when he must early need to refer to the secondary facility. This is my opinion. Thank you.
Thank you, Professor Budi. Câu hỏi này thì mình hỏi hiện nay thì có triển khai cái chương trình tầm soát nào về cái rối loạn chức năng sàn chậu hay chưa? Và nếu có thì đối tượng nào còn được thực hiện tầm soát? Thì theo ông Budi thì ở đất nước của ông thì ông sẽ sử dụng cái chương trình đó là ông sẽ sử dụng cái thang điểm PISA score giống như nãy ông đã trình bày. Và nếu như những cái bệnh nhân nào mà nằm trong cái đối tượng nguy cơ cao thì sẽ thực hiện được siêu âm. Và cái chương trình tầm soát thứ hai là ông sẽ sử dụng cái công nghệ siêu âm của ManRay, đó là cái Smart Bandwidth để siêu âm tầm soát cho những cái đối tượng phụ nữ. Và ông nói rằng ở mình thì ở các nước Đông Nam Á thì do về vấn đề về văn hóa, về chủng tộc thì nó sẽ khác so với các nước phương Tây, nên là ông đề nghị là con sẽ có một cái chương trình tầm soát riêng dành cho phụ nữ Đông Nam Á, và có yêu cầu là chúng ta cần phải là giáo dục cho họ biết để cho có những cái phát hiện sớm. Rồi câu hỏi của mình hết chưa Tiên?
Yeah, hết rồi. That's all for the question. Thank you, Dr. Budi and Dr. Fanini for your you so much. So we will stop the webinar right now, and then the rest of time I will make the post-it for the attendee to getting the CME. So every panelist you can say goodbye and we can lock down now. Thank you once again. Thank you so much for joining us today.
Should
Thank
we
you.
take
Thank you very
pictures?
much.
Yeah, thank you.
Okay, we can
Thank you.
take